Well, let's make sure everyone can hear me fine. And if you can't, give me a thumbs up, thumbs down. Thanks, Don. And as I look out, I see that there's kind of a spectrum of people, from fellow healthcare providers to patients of mine, more than a few, and probably some of you that are here because you have a vested interest in the topic. So with that said, I want to cover probably a little bit less than everyone would like to cover in individual areas, but try and cover a lot of these topics more broadly. If I could do nothing more than just give you a little bit better understanding of backs and back problems, I think that would be enough, because I think as I communicate with my patients, I'm always finding that things that I take for granted as being just part of my background knowledge, other people don't necessarily have, and it helps you understand your own backs and your own problems to know just a little more about them. So first, the obligatory, who am I and why am I talking to you? So briefly, and it's a long story, I grew up here. I came here when I was 3 months old. My parents were hippies from Monterey who lived in a tent the first 6-7 months of our life here, and then it snowed too deep, so they found a house. I graduated from South Tahoe High, and out of high school I became a paramedic in Reno, Nevada. And I was a paramedic through med school, so all total about 9-10 years. Somewhere along the way, healthcare brought me into medicine, and I went to med school at the Nevada School of Medicine and then trained in orthopedics in New Mexico. After that 5 years there, I did an additional year of training in Boston with the Harvard system in musculoskeletal oncology. Tumor surgery was sort of my first love, mostly drawn to the patient populations and the patient's pretty compelling need for somebody to help them out. But I felt limited in the fact that most tumor surgeons don't intervene in the spine. So I also did an additional year of training in spine surgery at probably the busiest spine center on the planet in Seattle. That led me to, after about 9,000 miles or so, to a faculty position where I ran the spine division for the University of Texas in San Antonio. And despite the fact that I absolutely loved my job and loved my patients there, thoughts of home kept drifting in, and then a 2-year-old daughter was sort of a slam dunk for making it time to come home and time to be with family. So here I am, and here hopefully I'll stay. So we're going to touch on a few bases, but roughly neck problems, back problems, the difference between back pain and leg pain, and of course this is Tahoe, so we have to mention trauma and sporting injuries. Like I said, we'll just sort of parse a few of these and get into a little more detail with others. There's a lot of terminology, and I don't want to get into any of that. So at any point anyone has a problem with words I use or problems we bring up, you know, you look at this list and it's daunting. And there's a lot of Latin thrown in there for good measure. So I don't expect that to be the focus of our talk. But we want to note that a lot of this stuff covers the spectrum from a perfectly normal spine like that to the lion's share of my practice in Texas, which was adult spinal deformity and complex spine surgery. But it's all rests on the same basic principle of the human spine, which should be, and do we have a laser pointer by any chance anywhere? Or I might be able to do a cursor if I swirl my finger around for long enough. Maybe not. But so the spine is built for economy, because everything in our body is meant to have a certain efficiency. Otherwise, we use too much energy. It's too much work to do what we do. So the curves in your back and a normal shapely cervical or neck lordotic curve should be compensated by a nice gradual thoracic or chest curve that bends the other way, or kyphosis. And that, of course, is balanced by the lumbar and the sacral curve. So it all seeks to place your head above your hips. And people like being that way, and when they're out of that alignment, people don't like being that way. And my specialty has done its fair share of flat back surgery during the 70s and 80s to know that people desperately need to be in good alignment. But the spine is at both times separate with functional spinal units between each vertebrae and also interconnected. You really can't literally separate the head from the spine. It's all part of a continuum. And that said, so our wiring, if you will, like the Romex in this building, is the brain and the central nervous system. Spinal cord runs down the center of the spinal canal to about the level of L1, and then it fans out into, again, another Latin word, cauda equina, or horse's tail, and those are all the lumbar nerve roots that go out to your legs. But the basic concept here is that while they may coalesce into groups of nerves that run down your arm in the brachial plexus, or groups of nerves that run down the back of your leg in the sciatic nerve, they each retain their individual identity as spinal nerves. So if one of you comes to my clinic and says, you know, my thumb and my index finger are burning, my mind immediately shifts to the C6 nerve. Or if, as some of you have may heard, or, and I know actually experienced in this room, had a foot drop, that's usually either the L4 or the L5 nerve, or both that are impaired, and they affect the muscles of your legs. So listening to you and associating with what you guys tell me to what I know about the wiring, that's the first step in understanding your problems. Because in addition to just the wiring, you know, nerves move our muscles. They provide the stimulus to get us around. And so muscle strength and muscle function is really important to me determining where lesions are. And we're going to circle back around to this because I think a common practice in spine surgery is to have you all go out and get MRIs before you come and see a spine surgeon, which is absolutely wrong-headed. You know, MRIs are expensive and they're costly and time-consuming. And I'd say it's 1% of the time where I order an image that isn't meant to reinforce what I already know from listening to you. In contrast, I shouldn't be looking for an imaging problem to fix that's disconnected from a pain in a person that needs to be corrected. So all of this wiring and anatomy is just sort of the backdrop for you all and how I listen to you. Back pain, which is probably a big reason why a lot of you guys are here, it's common. So probably about most of us will have it. And I'm one of them. I've had several really severe low back and a couple severe neck episodes in my life. And I have a perfectly normal MRI, perfectly normal imaging, which is problematic. Spine problems will be roughly the 5th leading cause of going to a doctor, not just a spine surgeon, but your primary care. And it's the #1 related reason for work disability. And that obviously brings a lot of dollar signs into the equation because that's a lot of missed work hours because of back problems and a lot of manpower to people who own businesses that'll be lost. But who gets it? Because I think you look at, I don't know, the cartoon and the picture and you say, well, yeah, obviously those people are at risk for back problems. And that's partly true. People who engage in heavy labor or are morbidly obese or sedentary, they have a higher incidence of back problems. But while these things contribute, if I were to pick one single reason why people in the audience have back problems, or I have, because I've seen my parents' MRIs, it's that your heredity largely determines your backs. And there's some pretty good studies following twins throughout their lives, literally, where some have been mason workers or carpenters, and the other was an office or desk jockey, and yet they have about the same level of back disability and back problems. So if you want to blame somebody in the room, if your parents here, look at them. So that also is a little disheartening because it means there's a lot of this equation that we can't control. We can only mediate the genetic information we're given and then take it as it comes. Further complicating this problem is that back pain is not back pain is not back pain. And I say that a lot in cancer as well. You know, if you look across the spectrum of cancer and malignancy, it's a breadth of unique problems and unique people. And the same is true with back problems. And if we try and identify why you have back pain, or you have back pain, or you specifically have back pain, it's really hard to identify the pain generators. Why? Because there's a multitude of them. There's the individual bones, there's the intervertebral joint, there's the bilateral zygapophyseal or facet joints, there's the nerves that supply both of those joints, the discs, the ligaments, the muscles that connect to the ligaments. I can keep going, and you'll get increasingly glazed over as I explain that, there's a lot of things that can cause back pain, and zeroing in on yours is very much a unique thing. It's part of the reason why, those of you that have been in my clinic, you can't really, I'll discourage you from going to friends and family and saying, well, what did you do with your back problem? Or how did your back surgery go? And it's a real apples to oranges problem, because people are unique, their problems are unique, and across this list of 40 or so pain generators, zeroing in on yours is very much an individual thing. But what I can tell you, which should give you some solace if you were starting to lose hope, is that most of this is very benign. Most of it is the equivalent of the ankle sprain. It's low back musculature, low back ligamentous strains and sprains and aches and pains, much of which happen in normal, healthy spines. And then a smaller portion of them are very identifiable problems like disc herniations or arthritis of the bones and joints, herniated disks, which are pushing on nerves, compression fractures, which happen from a lot of reasons, but mostly age and a declining mineral content in our bones, osteoporosis, and some of which is from, I get this a lot, is spurs and bone spurs in my spine, and what that's seeks to do is narrow the outlets for the nerves in your spine, so spinal stenosis. Then there's some more Latin words, which I'm going to actually go in a little bit more detail in, because they're one of the few things we do really quite well at. And then there's trauma. Thankfully, these things, as I go down this list, like abnormal vertebrae, congenital disease, malignancy, infection, these are very rare things, and you guys, by the numbers, probably have none of them. Another way of thinking about this is that most back problems have a mechanical origin for them. Again, it's either a sprain, strain of the muscle, or it's a functional impairment of the back. And it's not these scary things like tumors, infections, or as they say in medical school, hoofbeats that lead to zebras, not horses. Most of what we hear are hoofbeats from horses, not zebras. So, to some of the more common problems, and these are the problems almost in descending order of things we do better at, are identifiable mechanical problems. So herniated discs and spinal stenosis make up the majority, as you saw in the last slide, of spinal problems. But what does that mean? Because I have lots of people come in saying that they have a slipped disc or they have a bulging disc. And so if you look up at the diagram, really think of the disc as I do, because as any neurosurgeon will tell you, orthopedists are a bunch of dumb monkeys, and we think more about cars than we do physiology. And the disc is like a bushing. It's a bushing between two solid objects that cushions the bones as they interact with each other and allows motion. And sometimes that solid outer ring or annulus wears out, and so it allows the soft spongy material of the bushing to push out into where the nerves live. And when it does, it can pinch those nerves. And if there's one thing that nerves don't like, it's compression. And when they do, they scream out in pain, and they scream out in pain along their distribution. So again, back to the familiar sciatic pain, if it's pushing on one of the nerves in the sciatic nerve, then it's going to radiate down that distribution of the back of your leg down to your calf and your foot. And that's probably one of the more common reasons for radiating leg and back pain. Spinal stenosis is the other, and there's a bit of a confusion when we talk about cervical stenosis, because The cervix is a part of the female reproductive anatomy, but it's also the neck. And so stenosis by itself is just tightness. We have stenosis of lots of things. You can have stenosis of the pipe in your house if you want to think of it that way. It's a narrowing of the opening that should normally be there. But the problem in our spines is nerves, and our wiring's trying to get out of our spine to do its job. And when it's compressed by degenerating discs or arthritis or shifting of the spine, then it pushes on those nerves and sends that burning, lancinating pain down that nerve. Occasionally, in the worst example of both of these problems, you might have some underlying stenosis or a massive disc herniation, and it can actually block the entire canal. And that's sort of the public service announcement. There's very few spinal emergencies, but cauda equina syndrome is one of them. And that's where essentially a big disc herniation and about 1% of the time something more sinister pushes on all the nerves, including the ones that go to bowel and bladder function. So a sudden loss of bowel and bladder function, numbness or paralysis in your lower extremities is you're on the way to the emergency department, and in general have about 1 to 3 days to get that function back before it's permanently lost. So back pain, weakness. When we say saddle paresthesias or saddle anesthesia, that's where you sit. So genital numbness and tingling, and loss of bowel or bladder function is cauda equina syndrome. And that is an emergency. Back to our list of Latin. Spondy, which is spine. Spondylosis is really just arthritis of the spine. And spondylolysis is a lysis or a fracture of the spine. So sometimes, and this is actually really quite common, 6% of adolescents can have an adolescent spondylolysis, where often because of hyperextension sports or just being a normal adolescent active kid, you get this stress fracture between the front of the spine and the back of the spine. It's too bad that marker doesn't show up. And when you have that, it can cause pain in adolescents that if it isn't picked up usually goes away. The adolescent modulates their activity, they give it some rest, it heals, but it may not completely heal like it should. If they're not braced, it may heal with just scar tissue. And then the most common presentation of this in my clinic is the 40 or 50 or 60-year-old person, more commonly L4-5 in women and L5-S1 in men, where that scar tissue starts to loosen up. And that allows the spine to get flexible, and usually, or not usually, but sometimes can lead to a condition called spondylolisthesis, or slippage of those two spines, one with respect to the other. And that becomes problematic for a lot of reasons, one of which is it's really common. This is one of the more common things that we see. And that mechanical instability of the front of the spine and the back of the spine not really communicating, the spine moving in abnormal ways, whereas it shouldn't. And usually as the spine slips forward, that disc is taken along with it and also ends up pinning the nerves along the way, either the nerves at that level or the nerves that are trying to get down the spine to the next level. And so back pain, radiating leg pain are the hallmarks of spondylolisthesis. Fortunately, this is one of the things that if you come in, it's sort of good news, bad news, because a fair number, 80 to 90% of patients who undergo surgery after failing all the conservative measures have good or excellent results with surgery in spondylolisthesis. So while surgery is always my option of last resort, these patients do quite well. And again, as things get pinched, my biggest clue is y'all. When I listen to you and you tell me that you have pain that radiates down the anterior thigh to the inside of the ankle, I'm already going to be looking at the L4 nerve and what's affecting it. If you tell me that it runs down the back of your leg, down your calf to the bottom of your foot, the S1 nerve is the likely culprit. Not everyone read the anatomy book, so there's a little discrepancy. And all four of these nerves, L4, L5, S1, and S2, create the sciatic nerve. So we'll all call that sciatica, but it really may be only one or several components of the nerve bundle that create that pain. But again, by listening to you, I usually have all these answers before I order an MRI. And I'll even delay ordering the MRI so that you don't get a study that costs money, time, and then in a year, year and a half is no good to me because it doesn't reflect who you are today. So we'll try and temper everybody's urge to get an MRI or feeling that if they have an MRI, they'll have more information, because I really want it to be an effective study for you, not just additional information that doesn't help us do anything. Just some other sort of record keeping on things that you should not pass off as typical back pain. So again, saddle anesthesia, bowel and bladder dysfunction, that's more of a you need to see somebody right away. That can be, although rarely, cauda equina syndrome. Compression fracture, sudden onset of pain, especially not to have a gender bias in women over the age of 60 who have lost a lot of bone mineral density. And there are plenty of men out there with osteoporosis, but unfortunately women get the raw deal on this one. But sudden onset of back pain doesn't resolve in a few days. Even with mild or no trauma, that's something to at least raise the specter of, could you have an insufficiency fracture? Do you have a known diagnosis of osteoporosis? Or are you even checking it after the age of 60? And I think that's something reasonable to discuss with your primary care physicians. Other things that can make that more likely are chronic use of steroids, family history of osteoporosis, and there's certain ethnic patterns. It's really the thin white European female who gets the most of our osteoporosis. Certainly it happens in everyone though. Back pain also should never be associated with fevers, chills, and onset of constitutional symptoms. So when somebody tells me they have sudden onset of back pain, that doesn't relax with rest, lying down, comfortable positions, and is associated with anything like fevers, chills, unexplained weight loss, weight gain. Those are red flags that are going to make me look deeper and should make you see somebody sooner than later. So I do want to summarize a bit of the back pain discussion by saying it's real common. We all have it, or at least almost everyone's going to have it, and God bless you if you don't. Most of it's going to get better all on its own. That's why one of the best treatments a spine surgeon can offer is just a tincture of time. Rest, relax, go through some of the modalities which we're going to get into in a minute, and usually this is going to pass without a lot of worry. And again, we talked a bit about the important red flags in my book, and your providers know a bit of the more sinister red flags to look out for. But, you know, one of the things that I think is important is especially your all approach to back pain. And Texas taught me this, I think, strikingly, because every clinic I would see some 70, 80-year-old Texan who had been working on their ranch all their life and really didn't have an option. They were getting up tomorrow morning and they were going to go tend the farm or the cattle and do what they had to do, and they just kept moving, despite the fact that it looked like somebody stuck a hand grenade in their belly, closed their belly up, and ran away. They just worked through these things. And so it's hard to underestimate the power of my patients and my patients' patients, because we're going to have this. And so if there's one thing I can implore you all to have is an understanding that you're not unique to have back problems, but it's okay to work through 99% of them. We can get to it. You're not going to hurt anything. And it's rare the patient that I actually tell to modify their activities. Sort of a maybe somewhat politically incorrect version of a really true statement I heard in a lecture once is, as we age, we start to resemble sharks. And if sharks stop swimming, they drowned. And so I encourage you all, as you confront these problems, to keep swimming. And do what you can. I'm fortunate now in Tahoe because in other places I've worked, and now I won't name names, this has been a real issue. But Tahoe in general is a very healthy population. But just understand that some real good biomechanical studies show that every extra pound we carry on our core above the mean average is 4 pounds sitting and 8 pounds walking on our spines. And so if you have back pain and you're unfortunate enough to be over your body mass index, carrying some weight, or obese, every pound makes a difference in your approach to back pain, your overall pain, and complications if, God forbid, you need surgery. All are dramatically increased when we have more tissue to work with in the spine. So really, but what I don't want you to take home from that slide is I don't think anyone has to be on or should be on either end of that scale. It's sort of like Aristotle's golden mean. Somewhere in the middle, everything in moderation is about right. So again, I want to circle back to imaging studies because there's not only an expectation out there amongst patients, but there's a pretty big expectation among providers that patients should have imaging before they see me, a CT scan or an MRI. In fact, we're responsible for it because many surgeons just simply won't see you if you don't have your MRI first. And there's a financial motivation to that. You know, if we spend too much of our time not focusing on patients who are candidates for surgery, well, that makes it harder to run a practice. But I've always made it my practice not to encourage imaging. I want your providers to, when they identify a problem and they've given it some time and they've gone through the basic core stuff that we'll focus on, then send them my way. And then if I feel that imaging is necessary, that's when we'll move to the next step, to save you the expense, to save you the extra effort, because a lot of these imaging studies are frankly unnecessary. And we can do our part to control at least that cost and obstacle in healthcare. Yet, your providers should have good indicators for when they want to pull that trigger sooner than later. And if somebody truly has an unremitting pain that lasts more than several days, sustained for several weeks, that should be imaged. Certainly cauda equina should be imaged immediately. And if these red flags start adding up, constitutional symptoms, fevers, chills, that's another great reason to jump on imaging. So I don't want to discourage it entirely, but I do want y'all to have that understanding that an MRI isn't something necessarily that we need or want to have sooner than later, because it may unnecessarily fuel the train towards a procedure you just don't need. And certainly I don't operate on anyone before they need it. So now we'll get into a treatment light version for the providers in the room, and maybe a little bit too much detail, and feel free to give me the eyes and push me along if this gets onerous. But what do we do when you have a problem? And it certainly usually isn't that, which is a 2-level decompression infusion. So all of you have probably tried the non-steroidals before you reach my door. Ibuprofen, naproxen, Aleve, Motrin, aspirin. Understand that Tylenol is not an anti-inflammatory, but is good and effective for arthritic pain. That's sort of the cornerstone of conservative care. And the only thing I commonly see patients and providers do is more sporadic use of it. And for an anti-inflammatory to work, and now's here where I want to be specific to not get anyone into trouble, it really has to block the inflammatory pathway and keep it blocked. It's called the COX pathway, and it's chemical mediators in your body that give rise to actual inflammation. And if you block it early on in the pathway with these medications, they help decrease inflammation. But if you take it here and there, it's really just an analgesic. It'll help with your pain, and they're very effective at that. But you really do need to give it a little bit of a sustained benefit to be an anti-inflammatory. One of the byproducts of the anti-inflammatory medications is that it removes the protective coating of your gut, so you need to take it with an antacid or food. And certainly if you're having pain enough where you're having to take more than a week's worth of ibuprofen or naproxen, you know, it's maybe something to at least make the appointment for your primary care and start doing all the activity modifications, rest, heat or ice, whatever you prefer. And then if it goes away, you can cancel that appointment. But if it doesn't, you've at least given anti-inflammatories a fair shake. Yeah, Aleve, the real advantage, while they all share the same family, is that Aleve is a 2-time-a-day medicine, as opposed to ibuprofen is usually 3 times a day. Some of them, if you have a history, and this is again where we start to, the more you feel like you're depending on them, the more I encourage these conversations with primary care, because certainly Celebrex has a lot of bad press associated with heart conditions. But you know, really all the anti-inflammatories are of the same family, so it probably isn't just Celebrex. If you find yourself needing to take buckets of these, you should probably be discussing why you're taking them frequently.
You were mentioning heat or ice.
Yeah.
Doesn't heat increase the
So I think where there's let me do this. Let me make the distinction that for spine problems or orthopedic problems in general, I think ice is good for acute injuries. After that, so after you maybe fell down the stairs and you want to put some ice on something that's swelling, or you twisted your knee skiing and you want to put some ice on it, after that, really the data is inconclusive for heat or ice, and so then it's up to you. If heat's your thing, which it is for me when I have back problems, I absolutely take long hot showers, etc. If ice is your thing, I'm absolutely for it. So really it's the acute pain where I might lean you towards, or the acute swelling after an injury where I would say ice might be my preference. Again, motion is lotion for the bones and joints. We got to keep moving as people, and even if we have problems, pushing through them and being mobile generally helps them. So one of the most consistent histories I hear every day in clinic is of somebody who has a morning stiffness and pain, improves with a little bit of light activity, I'm starting to see heads nod, and then worsens with a lot of activity. That, my friends, is arthritis. We all get it. It's like gray hairs on our head. If we're lucky enough to have them, we're going to get some component of arthritis and pain. And motion is good for it, as most of you probably know, but too much activity can make it too much. Long drives exacerbate it, sitting in positions for a long time. Again, a lot of nodding heads because we all go through this. So therapy is beneficial, and the data is the best for physical therapy. Granted, that is moderate level of evidence by peer-reviewed studies, but it's the best for physical therapy. And there's actually some good data that says it's equally as good for yoga, and we'll circle back to that. As we start to encounter more of the nerve root syndromes, we start to think of anti-inflammatories beyond the over-the-counter medications, and that's where injections come from. And this is another helpful thing to people out there who suffer from back pain, is that I don't routinely get injections for people with back pain. It's generally ineffective. Radiating, burning arm or leg pain, very effective. Especially if we know where it's coming from. We can deposit a local anti-inflammatory steroid right down by the nerve and make it get better usually. And if it doesn't, it at least gives us diagnostic information. So I routinely hear patients, I send for an injection and they'll say, yeah, that was no good. After a day or so, my pain came right back. But they had a day of pain relief, which tells me we know exactly where their pain's coming from. And so it can be very helpful, and we may send you just because, even though the data is mounting that injections don't fix problems. We're tempered by the fact that all of us have patients who say, I got an injection 15 years ago and my pain went away and now it's back. And so they're still a worthwhile exercise. They're worthwhile to try and give you that relief, and it may tell me something diagnostic even if it's not long-term therapeutic to you. So injections are another pillar of conservative care. You know, this was a harder sell in Texas, but I think it's an easier sell up here. People are much more mindful, I think, here of the mind-body relationship. People live healthy, and I think they're attuned to the fact that our outlook on life is not only affect our back problems, but our back problems affect our outlook on life. So sometimes we'll even employ medications that have dual duty. Gabapentin, Cymbalta, duloxetine. These are medications that have mixed actions on both the nerve membrane, stabilizing the nerve, calming down its activity, as well as affecting the serotonin in receptors in our brains, which is what the antidepressants do. So we kind of double duty with some of these medications to help that mind-body relationship. But certainly, one step down from physical therapy and yoga in terms of levels of evidence is cognitive behavioral therapy. And unfortunately, insurance struggles with paying for this. We're working hard at the new center to have it part of our multimodal continuum of care. But cognitive behavioral therapy, or what used to be called in the 70s and 80s biofeedback, is clinically very effective for helping with back pain. So I just want to emphasize that because it's one of the things as we try and develop a well-rounded cycle of care that we're going to be paying more attention to. And the hospital's new push towards mental health, I think, is helpful in that regard. Sometimes, and oftentimes, we employ the help of other physicians who are geared exactly towards this. Physiatry, or the other name for the specialty is physical medicine and rehabilitation, are physicians in their own right, and they focus on exactly all this. Myofascial, musculoskeletal origins of problems and how to make them better non-surgically. They'll often do injections, blocks, interventions, and they are a resource for us to help navigate patients away and towards surgery. So they're one of my key allies in the battle against neck and back problems. Allison Ganong's in the Barton system and part of my group, and we've just hired, I think, committed to a second physiatrist who should be starting in the next year. And so we're definitely focusing on these interventional but non-operative spine providers. And then, you know, and I think it's unfair because when I talk about alternative therapies, I know what most people's mind goes towards. But over the next couple of slides, what I want to focus on is that there's a whole continuum of care out there, ranging from stuff with good levels of evidence, like chiropractic care, to yoga, to manual therapy, which is an offshoot of chiropractic care, yoga. And these are all like a potpourri or a buffet of things that we can pick from. I certainly send a lot of patients to yoga and acupuncture, and some of them will come back and say, that's crap. But we've tried. And some of them will come back and say, I really love it. I had a session of dry needling this afternoon and I'm pain-free. And I've got nothing to say about that. Even if a Cochrane review won't support it with a moderate level of evidence, I'm okay with it. And as long as it doesn't hurt you, break the bank, and gives you some benefit with little risk, I'm pretty much okay with a lot of these things. As time goes by, there's an increasing push in healthcare to make also these modalities scientifically accountable to what we're recommending. So hopefully we'll get more and more data as time goes by, and it's one of the main thrusts of the new center is to focus our care on outcomes and science. So you'll notice if you come into the new center that we're going to have a lot of intake forms and outcomes-based material that should gear us towards making this a more scientific-based endeavor. So then where do I come in? We're going to probably ignore a lot of what's said there because that list I could make as one of those ending trailers in a long movie, because there's a lot of things that surgery can be indicated for. But I think, and we've covered just 5% of them. But in the end, understand my bias. Spine surgery is the end of the road in terms of conservative care. That's a door that once I open, I can't close. And so I'm really mindful that That's a step that we take together when all that conservative stuff, or at least everything that matches you, fails. And that's honestly the way it should be. I've lived by one rule for surgery and one rule only, and that's I've indicated every patient for surgery for the same surgery that if that was my wife, my child, or my mother, I would give to them. And it doesn't mean it's always problem-free, complication-free, or 100% risk-benefit favorable ratio, but it's what I would recommend to them. And so no matter what in our circle of care, you should be at that point at the end of the line of all the things we've tried, and know that you've exhausted them before we take that step together. I think there's a few slides here that I want to talk about because there's a lot of disinformation's not the right word, but marketing's probably a better word in spine surgery right now. And while I do everything from the minimally invasive to the maximally invasive for global realignment surgery, oncology, or patients who have problems that you hope to never have, that at the heart of it, I'm a minimally invasive surgeon. But what you want is the right surgery. And it doesn't matter whether it's through a 1/2 centimeter incision or a 20 centimeter incision. My patients are happy because we direct the care towards them, not towards the current fads. That said, I do want to arm you all with a little bit of understanding of what we do, because it's really easy. Honestly, a guy tried to sell me on spine surgery in med school, and I kind of laughed him off because he said there's 3 things we do: decompressions, fusions, and decompressions and fusions. And so that sounds really boring, but there's some truth to that. And now we've added disc replacement to that list, which is becoming very successful in some necks. Pretty poor results in low backs, so we're moving away from it. But at the heart of it, let's roll through those. So a decompression is, again, if there's stenosis, if there's tightness on nerves, nerves hate that. So we'll remove it. And that usually involves some combination of removing the bone that's pushing on it, the ligaments that are associated with that bone, and just opening it up. Whether that implies, like in that case, almost a full laminectomy, where we remove the midline part of the back of the spine to just let the nerves float away from whatever's pushing on it, or whether it's more microscopic and focal. The point is where your nerves are compressed, that's where we direct our attention to. And if it's an incision that big through a tube and a microscope, great. And if it's several levels and a big open incision, again, you got to do what's right for a good result and a good outcome, not good marketing. And sometimes we have to do more than we want to, and it actually makes the spine unstable. So much of lumbar spinal stenosis is in places where we really just have to remove the overlying structures, and that can make the spine unstable. And we don't want to give you a second problem when you came in for the first, so that implies we stabilize the spine. That's where a fusion comes in. A fusion is taking an unstable spine and making it stable by making those 2 parts grow together as one. 2 unstable elements fuse together as one, make it stable, and that can add to your pain. Where fusion's gotten a really bad name is, and there's a famous New England Journal of Medicine study that I bet you all know, because it came out and said that 30% of people for back pain surgery got better, 30% were unchanged, and 30% were worse. And I think that's, again, draws me back to individuals, because the devil's in the details. If I just did back pain surgery in the absence of leg pain, or for spines that don't have radiographic instability, a tumor, fracture, something like that, I'd be an unhappy surgeon with unhappy patients. Yet it's actually pretty liberating to see that nearly all of my patients who are surgical are happy and grateful that they had it, even when we do pretty medieval things, like putting screws and rods in spines, something that I never thought was natural or helpful to the human body, and yet patients absolutely love me for doing it to them. So why would we do it? And we do it for just good reasons. And occasionally, especially more lately for certain problems, we're able to take care of both things. Open up the nerves, decompress elements in the neck, and keep your motion, which has some theoretical benefits to preventing wear in other places in the neck. Again, I wish this were the end-all be-all for low backs. So far, it's pretty dismal. I don't think we've reached that point yet where we're effectively treating non-unstable, non-radiating leg pain, back pain. One other topic is, again, this is Tahoe, and let's see if we can get this to work. Maybe, maybe not. But anyways, if you grew up like I do, then you at least had some risk of having this. And when we have to, the spine needs to be stable. It gets us around. It's like your feet. You can't leave an unstable spine, or like in the 60s, prescribe 6 months of bed rest and expect to have a good outcome. That may seem archaic and barbaric, but that's a 23-year-old who had that injury while riding in the bow of a boat, and is one of my favorite patients, and I'm one of her favorite doctors, because even though that seems like a lot, that gives her mobility back and her life back. So maybe you don't want to pay attention to the x-rays, but that's what we do. And again, just circle back to marketing, because I know all of you probably came with at least, or some of you came with a question about, well, what about lasers? And minimal incisions and minimally invasive surgery. And the short answer is, I'm for all of it. The problem is that if it seems too good to be true, it probably is. I don't know any credible spine surgeon in the National Association of Spine Surgeons, or my major organization, that does laser spine surgery. In fact, I know some people that I interviewed, one to work with me, who worked at the Laser Spine Institute, and admitted sheepishly that only 1% of their surgeries use a laser, and they're actually recruiting adult spinal deformity surgeons like myself to work there. So it's a bit of a bait and switch. But I think the point I want to make here is that this stuff is secondary. The size of your incision, whether I do it, and I do, through a less than 1 centimeter incision or a 5 centimeter incision, it's got to be geared towards you, not what you read on the Sky Mall magazine or on your flight from New York. Exactly. And again, most of those patients aren't getting that procedure. In fact, probably most, if not all of them. Yet, there is a pretty good explanation for that. It escapes me at the moment, but yet there is a pretty good explanation for that. I swear I put this on mute. It is on mute. That's not me. So, just a one last word and plug is, again, I came here not because I wanted to retreat to the mountains. It's because I wanted to take the same level of care that I thought every academic institution should have, but I wanted to be with my family. And Barton offered that opportunity with this new center and committing some real resources to creating a team that will give the highest level of care here as any center in the world. And I know, because I've worked at them, and I still am active in research in those organizations. We want to give you guys the best that we can. Because after all, it's not just you guys that live here, it's me too. So I'm happy to take questions. Yeah, that's my pod.